So we want to really make clear what a feeding disorder is. There are differences certainly in being, preferential in choices and then being a picky eater. What kind of things contribute to that? And then some of the different approaches that we have with the disciplines. And then also some helpful tips. That's the big one, is that you leave here tonight having some information under your belt that you can start utilizing as soon as possible. It's obviously, everything we give you is just, starter pack for sure. It doesn't replace that need for individual therapy. So these are just some beginning ideas and to get things brewing in your mind to see what maybe the next steps are, and see where things are for your kiddo. So for a lot of these disorders, we're looking at being diagnosed with a kid who's refusing to eat or drink certain things in a sufficient amount of quantity, and then different kinds of foods that are contributing to weight gain, and then meeting those nutritional needs. So we have anything that a kid needs to be able to really progress as well. And then also the different kinds of ranges are being able to refuse just solids in general. Refusing liquids comes up. We do have some kiddos that have to take nutrients in through tubes. And then that's where that tube dependence piece comes in. The liquid dependence is maybe nothing comes in a solid form. And that's anything that has to really be chewed in any capacity. Different selectivities of food types, food textures, and then not feeding themselves. So these are a lot of the different areas kids can have, range through all of this. We may start out with a child who is completely tube dependent, and then we work through the whole range of it. So it's never, always super simple. Sometimes it's really complex, and then sometimes we can work through it from, a different place. Go ahead. So we wanted to distinguish early on what the difference is between being a picky eater and a problem eater, because that's sometimes a term, like we hear that idea of being a picky eater all the time. But the difference is clear once you look at here. So a picky eater is going to be somebody who has a decreased range. They'll consume 30 or more foods, but to kind of stick to those. The foods will be lost. They get burned out because they eat them repetitively. So it's a kiddo that loves grilled cheese all the time. They'll eat it a bunch. Maybe they do tolerate different cheese in there, but they love those particular foods. They'll accept new foods on the plate to touch it. They might taste it. They're not necessarily showing huge behaviors when the food's presented, but they're just not super interested in it yet. They have at least one food from each of the groups. That's a big thing. They don't necessarily restrict into an entire category. For example, they don't only eat starches. They're eating a veggie, a fruit, a protein, a starch, things like that. And then after you introduce a food multiple times, they're much more likely in this picky eater group to incorporate it into their diet. A problem eater is where it gets really challenging because these kiddos are often restricting to less than 20 foods. It's a really small range. If they eat a food and then they decide to stop eating it, it often doesn't come back into their diet. You see these really huge behaviors often come up, sensory and behavioral. So way more feelings involved with these kiddos with introductions. That's more screaming, crying, throwing things off the plate, running away from the table. And then they'll refuse entire food groups. So vegetables will just be completely off limits. We have a lot of kiddos we see that do not eat any form of vegetable at all. And I know somebody mentioned in the beginning, smoothie or otherwise. It doesn't matter how you hide it. It's not happening. And then the thing that makes this really tricky is they may take a food, but it takes multiple times of seeing it over and over and over. So this is a big thing that we'll kind of bring up, is that one time of introducing a food to a baby or to a 9-year-old is not enough. They need lots of chances to learn about foods. So the other one area of this problem eater is that they're inflexible about the format. So that's going to be the presentations of the foods as well. So it'll be, I only eat dino nuggets. If I give me any kind of other chicken nugget, even though, yes, it's, chicken with breading, it doesn't matter. I'm very particular on that breaded, crispy outside. Maybe I'll eat a baby carrot, but if you gave me a whole one, then that might be really, really challenging for me to see just because it changed. You put something a little bit wet on the outside. I know it's still my pancake, but I don't know what you did to it. It's broken now. Or even literally my chip, my Pringle is no longer a whole Pringle, and it is no longer useful for me. So these kiddos are much more challenging. This is a big red flag for when we're going to try to like look for intervention as well. It does not typically improve without support. So these are just some of the, from a lot of the clientele that we work with, these are some of the factors that we see in kids that we bring up. In, a lot of this early intervention services, we see quite a bit of kids on the autism spectrum. And so about 70 of the kids with autism spectrum disorder exhibit some type of selective eating. That's a lot. It's very rare, to be honest, that I get a kid where they're like, I'm not a parent that tells me I'm not worried about it. But I mean, I could tell you on my 5 fingers, I think that's probably, but most of them, it happens all the time. And it's also estimated that about 65 to 85% of kids with ASD also have sensory processing disorder. And basically what that is going to mean is any type of input that you're getting from the surrounding environment, any of your senses, you're not taking that information in and processing it appropriately. It's going to come through maybe stronger than it should, or not strong enough. And so when we have these kiddos that are picky eaters, typically we have kids that are much more responsive to smell, taste, the visual portions. So they are just constantly on high alert. Their bodies are being bombarded all the time. So we have to be very careful about how we present foods to them. I do want to make it clear, though, that there are times within, one of the things is there's typical periods for kids to regress in their feeding. So we do have to filter that through and figure out what age they're at and is it appropriate? Because there are times like my nephew went through an entire year where he mostly ate quesadillas. Leading up to that, he would eat sushi and he would be grabbing salad off my plates and all the things. He made it past that period. So there are things that are, typical to show up. They do show up later on as well. Around 9, kids get picky again. And then around in their teenage years, they start to regress again. But then they work through those things. So there's a difference between that. Another thing that shows up a lot is GERD. This is going to be that reflux. We have lots of babies that start, and that's a lot of those colicky babies often have GERD. They are super hard to soothe. They don't sleep well. But there's a big correlation between being a picky eater and GERD, and as well as food preferences. So for kids who tend to be more acidy and are having a lot of reflux, they often are looking for liquids to help, keep that acid more neutral in their belly, as well as, we have to think if our belly's upset, what kind of foods do we prefer? So we see a lot of these kids with GERDs preferring starchy foods and more bland foods. They don't do spicy flavors. So some of that really contributes a lot, and we have to work from the medical side as well to help support them. A couple other things is tone is a huge thing. So we do have kids that just with their diagnosis alone, low tone is very common, but it's not, reliant on a diagnosis. Kids with Down syndrome, that's one of the factors for them. They have to work, they're working really hard with all of those pieces. So if you are trying really hard to get your muscles to work, it makes things like breathing harder, holding yourself up, being able to hold utensils, 20 minutes of feeding with my arms. If everything else is hard, it's going to be less appealing. So I'm less engaged in the meal and I might want more support or eat less, as well as having endurance with chewing. So the more dense foods are really hard for me. And then another piece of this is anatomy. We do look at, what does their palate look at when you get into the top of a kid's mouth? Why are they struggling with some of these foods anatomically? Is food getting stuck up there? Do they have the oral motor skills to manage that? The number and the position of their teeth. So, little babies can only chew little bits because they don't have the sufficient anatomy, as well as having low tone cheeks. They're not strong enough to keep the food stuck and working and playing air hockey back and forth with the food, as well as we do face with tongue ties and lip ties as well, which make it really hard to manage food. In addition to, this is why we have the multidisciplinary approach, because speech is able to manage some of those other pieces when intervention's needed or finding strategies as well. So some of the factors that come up with this for the oral motor skills that we kind of just touched on. First off, feeding is not an innate skill. It's something that's learned. If you gave someone a G tube from birth, they would never know how to chew. So it's something that you have to actually have the interaction in the mouth. And take things in, and then have different complexities of that. So taking in liquid is, a different thing to manage than chewing on a graham cracker, than managing cereal and milk at the same time, and then like chewing up beef jerky. All of those require very different skills. Feeding requires you to coordinate your tongue, cheek, and lip all at the same time. So that's what makes it really hard, in addition to breathing and the other things that we mentioned previously. So that plays a big role. And then swallowing requires the ability to control food in the oral cavity, safely move it back, and then start the swallowing process. So that's a big piece as well, because if you don't do all that thing, that's when we see the gagging and the choking as a defense mechanism. Oral motor skills include like chewing the food, swallowing, having proper lip seal, being able to keep those lips together so that the food isn't falling out or you're not getting excess air in while you're eating. The cheek movements, so being able to keep them puckered tight enough that the food can stay in the teeth, and the tongue keeping it pushed over. And then what we see, like some red flags for this, symptoms of when kids are having deficits, poor chewing or no chewing. I have lots of kids that you just see them kind of mashing the food back on the roof of the mouth, and almost like suckling it back in the way that, like, if you were sucking on a little applesauce packet. Different types of food selectivity by texture, because they can't manage it a lot of times. A lot of these little kiddos, they may not even be super picky eaters, because this is feeding in general, but they also might not be able to manage really dense foods. So that's another red flag. Even if you give it to them, they're like, "Oh, chicken's good, but I pushed it out because I can't do this." Inability to advance to age-appropriate foods. So they stay on purees much longer than appropriate. Or even those mashable foods. There's kiddos that we have on raviolis at 5, 6, 7, because they don't learn how to chew denser foods. During meals, we see them coughing, gagging, sometimes vomiting, because they all combinations of maybe the food gets stuck, the texture is really tricky for me, it's gone down and now I'm gagging on it, or the vomiting is like, a lot of times will happen if it's too big, or it didn't mix with my body, or even if it hit and I've gagged and coughed so much that I'm now vomiting. Those are really big red flags. If we have kids that are getting food stuck in their mouth, so like, 2-3 hours later, we look and all of a sudden you're like, where did that come from? That's not a great situation. It means there's a lot of lack of awareness and management of the food. Food's falling out of their mouth. So when they're eating, it's just constantly coming out. And then aversions and hypersensitivities. So that might be to anything, toothbrushing, holding certain things to their face, getting their face washed. A lot of those things contribute as well. And that kind of goes into that oral sensory piece. We have kids that are either hyper, meaning it's over, or hyposensitive, so under, so to texture, taste, and temperature. So if it's texture, like they don't care, it doesn't matter. They'll have a ton in their cheeks. They'll mash it all in there, doesn't matter. Taste, you have both sides. You have the kids that are very sensitive, everything's very bland, or then you have kids who are eating flaming hot Cheetos at 2 years old because they aren't sensitive to it. It doesn't matter how their stomach is registering it, or the backside, but they are still not picking that up. And then temperature too. Like you'll take things out of the oven, kids will pop it in their mouth, and you're like, no, it's too hot. That's a concern for us. It's obviously a safety concern. And then the hyposensitivity can also lead to limited awareness of a bolus. That's what happens when you chew up a food, saliva combines and your tongue and your cheek coordinate it. It's supposed to, typically what we see is one thing that's like a red flag on here is if you see a kid who's been chewing a particular chunk of food, they open their mouth and it's scattered all over the place. That's a red flag for us, because it's telling us they aren't properly forming that little bolus we're talking about. Their tongue and their cheek are not doing their job. And then one of the big areas is, with a lot of these kiddos, 61% of children with feeding problems had an oral motor deficit. So that's contributing a lot to what they're managing. So some of the things that we consider for the physical and the environmental factors are how important positioning is. Proper positioning plays a huge role. It's one of the first things that we address in OT. But anybody that's working on feeding, it's a really important piece. Speech addresses this a lot as well, because it contributes to so many portions of respiration, as well as your positioning of your head and neck. So when we do that, if a kid is not having to work so hard to hold themselves up, they're going to have that much more skill with being able to manage their body to feed themselves, as well as swallowing. Everything is aligned properly to work in their favor. So there's a couple pictures on the sides here. You can see there's some examples of a quick fix. They make lots of fancy seating. Honestly, for some of us, it's very frustrating that they make as so many kinds of seating that are poorly made, where the kids are horribly positioned. You're like, there's nothing for them to hold on to. They're sitting all the way back and slumped, and their feet are just flopping around. If you feel like you're floating in space, it's going to be challenging to focus on what you're doing. So this is somebody who modified this to position this kiddo in a 90-90-90, meaning their hips are positioned at 90 degrees, then their knees, and then their ankles. So all they did was add a little chair underneath, and they went from, being slid back and not knowing where they are to being able to come upright, nice and tall. So that's one of the first things, if I could say like one thing to take away right away, that would be one of them. And then making sure the environment is supportive. So we look at modifications that you can do to that in terms of the noise, where we are in the house. Is the TV on? Are we using an iPad? All those things, what's happening around them? Is there somebody next to me playing? Is the dog coming by and trying to eat the food off my plate because what a fun game? What is contributing to how much this kid can pay attention to what they're eating, as well as sensory-wise, what the environment's like for them. How long they should be expected to sit. We definitely look at setting timers for kids as needed, but realistically we shoot for about 15 to 20 minutes for a snack, and then somewhere between 20 to 30 minutes for a meal. Kids who are eating really slowly and taking a long time are much less likely to take in as much volume, actually. So a kid that's sitting for 60 minutes, you're down to a battle now at this point. We're just kind of begging that kid to eat. And so, we work on as well, we're with families trying to set up a structured routine and schedule that helps contribute to better intake of food, better appetite management, because all of that contributes to how much food a kid is going to take in. And then last thing is, does the kid have the strength and endurance for everything that we're asking them to do? So, that's obviously a lot. Do they have the core strength, the arm strength, the jaw strength, the strength in their tongue, their cheeks, everything? We look at all of that, and that's where this whole multidisciplinary approach comes in, because each member of the team is going to look at that a little bit differently and find a way to support this kid. So this kind of just speaks to a little bit, I'll just broach a little bit on some of the sensory factors that we look at. And OT is a big thing with our kids who are suffering with sensory processing disorder. Their bodies are just constantly overwhelmed a lot of times, especially picky eaters. So just looking at distractions in the environment, these are some examples here. And then sensory stimuli, sometimes we don't realize. A lot of our kids are very sensitive to lighting within the room. We have flickery lights in this building sometimes, and all of us are struggling. So we adjust them and get them fixed right away, because it's not fun for anybody. But the kids, a lot of times, are very sensitive. It's distracting during mealtime, and it makes your head hurt. Smells in the room. I remember my mom used to cook with oil. I'd be upstairs and just offended. I like things cooked in oil, but even still, it would ruin my appetite. But that's any kind of food. It could be anything. Temperatures. So is it too hot? Is it too cold? If you're freezing, you're trying to maintain strength and warmth, you're not gonna be focused. Then how noisy is it? A lot of times it's telehealth is a great avenue, but it gives us an insight. Like we're trying to work on something and I hear 3 different things happening. I'm like, the kid is this way, this way, this way. It's really tricky. He's trying to focus on food. And so we start working on what are some easy fixes? And these are some places we start. And then lastly is just how food is presented. These are some examples on the bottom of different ways we manage it. When we're working on feeding, we have things that are divided so they're not touching because, God forbid, broccoli get near my watermelon. And then using the middle is using a very neutral blank slate so that there's nothing distracting. I'm only focusing on my food. And then on the right there, I feel overwhelmed with how that's presented. That's a lot of food and also a lot of things that like I couldn't tell you most of the things that are on the plate. So I'm going to be much less inclined to try things because texturally I can't differentiate them easily. I don't know what I use a utensil with, what I don't. And then these are some examples on the far right of kids that are kind of dealing with some of those distractions with like animals and, you know, using an iPad to kind of keep their attention and keeping them at the table, as well as a kiddo that's got a TV in the background. If we're trying to engage them in, new foods, we can't compete, to be honest. So that's why this becomes a really important thing. And I think right now we'll let Highland take over.
Okay, so this is a great slide. I'm willing to bet that almost all of you on this webinar right now could list about 20 of these if your child has feeding difficulties. Feel free to share in the chat if there is some sort of aversion that your child demonstrates. We would love to hear it. But what does food aversion look like? It's really obvious, right? Your kids are going to be turning away from the food or the table, pushing the food spoon or your hand away, attempting to leave from the table, crying, gagging, coughing, rapid blinking. They might even look really sleepy, like they're going to fall asleep because they're exhausted. So it's very obvious, but I think a lot of times as parents tend to think that it's a behavior, right? It's just, I don't want to do this. I don't want to sit at the table. I don't want to deal with this. And for some of our kids, maybe that is the case. But for a lot of our kids or all of our kids that have these food, aversions, it's very obvious. And these are key things to look for. Again, if your child, we encourage you to chat with us and send us a chat if you see something or that your child does that's different than what we have listed. We'd love to hear it. But yeah, these are very clear signs that your child is not interested in the food and the way it's being presented.